Can't hear you, Roman.
I can't hear anything.
Welcome everyone to this 11th episode of worldwide webinar by WSPOS. Today we are going to have a webinar on pediatric neuro-ophthalmology. Again, a warm welcome to everyone. Before I introduce our today's presenters as well as discussant, I have some announcements to make. The number one is there are some questions which are going to be shown to the audience during the course of the presentation. You can open this website on your browser, either on your cell phone or your laptop, www.menti.com, MENTI.com. The passcode for today is 384857. That is 384857. So this is the website. And if someone of you want to use this QR code, this is the code for today. You can keep it open. The questions will keep coming as and when the presentation comes. This way we will know what is the opinion of audience, as well as we can have some discussion around that. And audience questions can be sent from Blueberry, Facebook, or YouTube platforms. Type your questions. We will send it to the panel as soon as we see it. If some of the questions are not answered, it will be answered later. I just want to introduce today's discussants. The first one is Dr. Dan Melia. He's a French neuro-ophthalmologist. Currently, he's a professor and senior consultant of neuro-ophthalmology department at SNEC. And he's also head of visual neuroscience department at SNEC. We are very glad that he could join us today for the discussion. The next in line, we have Dr. William Good. He has kindly agreed to be a discussant today from he has come out from his busy schedule. He is a senior scientist at Smith Kettlewell Eye Research Institute, and he practices pediatric ophthalmology in addition. And as you all know, he is the editor-in-chief for Journal of American Academy of Pediatric Ophthalmology and Strabismus. His current research revolves around visual cortex in babies. He has done immense research around this topic and contributed. The third discussant is Dr. Clara Landau from Switzerland, Zurich. She's done her neuro-ophthalmology fellowship from UCSF. She was a past president of UNOS, that is a European Society of Neuro-Ophthalmology Society. Since 2018, she is in charge of residency program there, and also gender equality at University Hospital Zurich. Welcome, Dr. Clara Landau. Her hobbies are, she's working on the NGO called Light for the World, and she likes to hike, music, and shoot. Welcome again, Dr. Clara. And Dr. Rich Hurtle is moderating along with me today. As you all know, he is a nystagmus guru. He is the Chief of Pediatric Ophthalmology and Director of Children's Vision Center at Akron Children's Hospital, Akron, Ohio, USA. You can see this is one of the pictures where he came to India for teaching. He comes, he likes teaching, and he travels around the world to teach. And the second picture is when he was in Hyderabad for the World Society of Pediatric Ophthalmology. I let Dr. Richard Hurtle to introduce the rest of the panel. In the meantime, when he is introducing, there'll be one or two questions will be there on the Menti. Please go through it and submit your questions. Dr. Hurtle, over to you.
Thanks, Ramesh. Welcome to everyone. Before I start these introductions to our remaining speakers, it's certainly a pleasure to be part of WSPOS number 11 webinar. As we do these, we learn more. We have developed an audience. I think that these novel way of communicating and connecting has allowed us to also be a part of an international expertise, which is really the fundamental philosophy of WSPOS, is that we all around the world have something to contribute. So it's really an honor for me to be part of this again. One of our presenters is Dr. Ashke Badakir, and he joined LV Prasad in 2015. His interests are pediatric cataract, neuro-ophthalmology, and genetics. He's a runner. He's also a dad, it looks like, and a husband, and he would like to do a half Ironman in the next 3 years. Thanks, Dr. Bakadir. Dr. Eva Gadzofas, I'm sorry, Eva. I pronounce her last name correctly. She will correct me after this, but I know Eva well. We've done some work together and spent time clinically together as well. She's a wonderful person and a very nice woman and an excellent ophthalmologist. She's consultant in pediatric strabismus and neuro-op at the Royal Eye Infirmary at the University Hospitals as part of the NHS. She's a university fellow at the Faculty of Health and Medicine, Dentistry, and Human Science at the University of Plymouth, and she's done fellowships in pediatrics and strabismus at Great Ormond Street and Moorfields. And she's an outdoors woman with hiking, running, swimming, photography, and traveling. And it's certainly a pleasure to have her as part of this panel. And I know my brother in India, Dr. Ramesh, everybody knows Dr. Ramesh, and anybody who ever meets Dr. Ramesh wants to spend a lot of time with him. He has a very warm and engaging personality that belies a keen intellect, and I'm always happy to work with him. Thanks, Ramesh. And one of our speakers today is Dr. Preeti Patel Dablani, who's here in the United States and was at UPMC Children's in Pittsburgh. She did her fellowship in strabismus in Nethrala, Chennai, India. She did a visiting fellowship in neuro-op and pediatric ophthalmology at Shiley Eye Center with Dr. Granite. And she's on faculty with pediatric ophthalmology and neuro-ophthalmology at LV Prasad in Hyderabad for 7 years. And she has an interest in pediatric neuro-op and strabismus. And she's a reader, a baker, and a traveler. And of course, she spends time with her beautiful family pictured here. Thanks, Preeti. And with that, we will start with Preeti's presentation and the first case.
When Preeti is setting up her presentation, 2 questions will come during the course of her presentation. Please answer them on the Menti. Thank you.
Right, so is my screen visible?
Yeah, go ahead, Preeti.
All right, so firstly, thank you very, very much to the WSPOS for this wonderful opportunity. I'm really glad to be here. And good morning, good afternoon, good evening to everybody who's listening based on what part of the globe you're in. So I'm starting off with this first case. This is going to be an afferent case. So it's going to look at what we do when we hit a block. So this is a case of a 16-year-old boy with a pretty complex past medical history. He had type 1 diabetes mellitus. He has depression, ADHD. He's had multiple past admissions for diabetic ketoacidosis, or DKA. He also has a history of very poor compliance to therapy and poor follow-up in general. So this kid presented to the emergency department with vomiting and difficulty breathing. His initial labs in the ED showed a very high blood glucose of about 739, a pH of 7.12. He was admitted for management of his DKA and blood sugars. Now, this was his 7th admission for DKA in the last 4 months. On day 2 of admission, he complained of sudden chest pain and an acute breathing difficulty and worsening headaches. Now, he had been complaining of mild headaches ever since he got to the ED, but he said there was a sudden worsening in his headache. A CT chest with a CT angiogram was done, which revealed bilateral pulmonary embolism. An echo confirmed that he had right heart strain, and he also had thrombi in his iliac veins when a 4-extremity ultrasound was done. Neuroimaging was carried out, and the MR venogram showed extensive dural venous sinus thrombosis involving the superior sagittal sinus, the vein of Galen, the straight sinus, the left transverse sigmoid, and internal jugular vein. The angiogram was unremarkable. The brain did not show any evidence of an infarct. The parenchyma was largely normal. He was emergently transferred to the PICU and started on a heparin drip. Now, at this point, ophthalmology was consulted for an inpatient evaluation. When his vision was checked at the bedside, this is his near vision, was 20/25 OU. Pupils were reactive, there was no APD. He didn't do too well on the color vision testing, but then he's previously known to have color deficiency. He had good ocular motility, and this is what his fundus looked like. So he had bilateral disc edema with a few cotton wool spots, some hemorrhages. It appears to be a little worse on the left as compared to the right. So at this point, I'm just going to stop and ask our panelists. This is now pseudotumor cerebri secondary to a cerebral venous sinus thrombosis. So how often do you see this in your clinical practice in children? What are the common causes, and what are the treatment challenges, especially given the systemic status of some of these kids?
I think Dan can begin the answer.
Yes. Thank you very much, Preet. This is a very nice presentation of a somehow difficult situation. I'm trying to answer your questions. How often do I see CV sinus thrombosis in children? The problem is I'm an adult neuro-ophthalmologist, so the answer is very rarely, but it can happen, of course. The common causes are one of those that you are mentioning, venous sinus thrombosis or intracranial masses. We have a very active neurosurgery department, and so seeing intracranial hypertension secondary to tumors is not uncommon. And the challenges are, of course, very large. I think you'll discuss this more later. The fact that heparin has been already initiated might be a problem if we're going into a surgical solution for this. And of course, the absolutely critical thing, you want to keep vision of this kid. I also think there are a couple of other challenges in the differential diagnosis, because when we're talking about the combination of pancreatitis and DKA and diabetes mellitus, I mean, the portrait retinopathy can be one of the situations that come to mind, and there are other various differential diagnoses.
Any quick comments from Dr. Good or Dr. Landau?
Yeah, this is Bill Good.
Clara.
When this was presented initially, I thought, well, maybe there's some sort of hyperviscosity syndrome that's occurring. The child is dehydrated, and that's leading to the thromboembolism problem and the sinus thrombosis. But when you look at his fundus, his blood vessels don't look particularly dilated or tortuous as you might see in somebody who had something like that. So I'm not sure that accounts for all of this, but it still is, I think, a consideration.
I just wanted to add that one used to see this not frequently, but in children with, bad course of an infection of the middle ear, actually. These bacterial infections sometimes led to these very bad infectious venous thrombosis. So that's the setting. I remember some children having seen that. But here, I think it actually does fit to venous hypertension due to that thrombosis. And the problem really is how to deal with it. Heparin is one thought, which of course then makes it more difficult to treat with some kind of a surgical decompression of the like optic nerve sheath fenestration or a shunt. But that's just to answer the question whether this is seen much. No, it's rare, but it exists, and it's a very important cause of severe and sight-threatening papilledema.
I think Clara refers to the Gradenigo syndrome after otitis
Yes.
media complications, which is
Yes.
that is very rare in this post-antibiotic era.
Yes.
Okay.
Well, I have seen it.
True.
I think we will move on from this. As we are watching, as we are going through the webinar, we have people from Brazil, Peru, USA, Australia, UK, Greece, Saudi Arabia, Indonesia, India, Spain, France, Singapore, Zimbabwe, Nigeria, South Africa, Pakistan, Turkey, Iran, and Afghanistan, Russia and Lebanon, Bahrain, Greece, and UAE. Many countries are tuned in. I like Preeti, go ahead with your slides. And in the meantime, I request the audience to come up with the answers on menti.com.
Right. So the pseudotumor here was thought to be secondary to dehydration. He did have a complete prosthrombotic workup, and all of that was negative as well, just to rule out any secondary causes. Now, the challenge really here was balancing his systemic condition and trying to get the pressure down as well. So he had severe dehydration. His DKA was still sort of not well controlled. He had heart strain and severe systemic thrombosis as well. So at this point, we discussed with neurology and hematology, and it was decided that it would probably be better to hold off Diamox or acetazolamide at this point. Anticoagulation was continued per recommendations from hematology. He was initially started on heparin, like I mentioned, and then transitioned to Lovenox, which is enoxaparin sodium. He was advised of very close follow-up upon discharge with neurology, hematology, and ophthalmology. As luck would have it, it happens when you don't want it to, but he was completely lost to follow-up for 2 months. He then presented to the ophthalmology outpatient clinic with history of blurred vision in his left eye. Now, up to this point, he had never really had any visual issues. He did complain of headaches, but he'd had 20/20 vision, never had any visual complaints. He still had some mild headaches, no double vision. At this point, though, his vision in the left eye had dropped to 20/60. His near vision had dropped a bit, 20/30. Colors were the same, but he did have red desaturation in his left eye. He had an APD now in the left eye. His motility remained full. And now this is what his fundus looked like. So there is obvious worsening now of the papilledema. You can see these angry red-looking discs with multiple cotton wool spots. We see the exudates now as the fluid begins to track into the macula, and it's definitely worse on the left. These are his fields at this visit, which show the enlarged blind spots in both the eyes, again worse on the left. So now again here, at this point, I want to ask the panel, how would you change your treatment plan now, and how would you follow up?
Am I supposed to answer?
Yeah, go ahead, Dan.
Yes, right. So I think this is a complication of intracranial hypertension, which is turning probably now into a malignant, probably form of it, with a quite clear left optic neuropathy, which requires intervention. Otherwise, this poor child is at risk for losing vision for sure in his left eye and probably in the right eye. So the first question is, I would discuss this with the pediatric neurologist. How important is it to keep anticoagulation at this time? How far are we now in the course of the disease, Preeti? 2 months, 3 months?
2.5 months approximately.
2.5 months, right. So I think after, well, I mean, anticoagulation is probably kept for more than 3 months, but I still it's worth discussing. Since headaches are only mild, the problem is not as much curing the systemic problem, but probably locally. So I think an interesting option for this would be to discuss optic nerve sheath fenestration. I would certainly image again because we don't know what is happening. I would like to be sure there is no additional venous sinus thrombosis. There is no reason for intracranial hypertension to get worse, in fact, edema to get worse despite effective treatment. So that would be probably my first step, to be honest, to see if there's not additional extensive sinus thrombosis to deal with that, and then try to treat symptomatically vision and to preserve vision.
Then to make sure your choice is more of a surgical, at this point of time, if it is allowed in terms of.
If there is no worsening of the sinus thrombosis, because it's still not clear to me, why is this kid getting worse despite his treatment?
Okay. Dr. Good, you have any quick comment to make at this point of time?
Well, I mean, I agree with the other observers. I think we probably could assume that with 3 months lost to follow-up, he hasn't really been getting treatment that he should have gotten, or at least probably hasn't been getting it correctly. So I think my first approach would be a medical one. I want to be sure that you have his diabetes under control. Getting back to the dehydration viscosity issue, you'd want to hydrate him very carefully and make sure you've got all of that taken care of. I don't think this is a dire emergency. He's had this developing and evolving over the course of several months. So I think you've got several days to a week or so to see what happens just with a good medical intervention. If you're considering a surgical intervention, then clearly you don't want to start him on anticoagulation. I'm assuming that he's been evaluated very carefully for the other conditions that can cause thromboses, and that those have been negative. I think we heard that earlier. But bottom line, I think I would still take, at least initially for the first several days, a very careful medical approach and try to get him as hydrated as possible and see what happens.
So, does this kid have pancreatitis? Is that one of the problems?
No, he did not have pancreatitis. He had uncontrolled diabetes and dehydration leading to ketoacidosis, diabetic ketoacidosis.
Wow. Does he have, is his hearing okay? Does he have anything that might suggest some other syndrome that causes diabetes mellitus?
No, he was evaluated by genetics as well. There was nothing else.
Mm-hmm.
So just because of our time, I would certainly throw one thing in there, because pulmonary embolism is such a rare condition in a kid. We cannot live in a COVID era without throwing the COVID diagnosis in, which we know can cause delayed pulmonary embolism. I apologize for suggesting that.
This was about 8 or 9 months ago. I'm really hoping it wasn't COVID.
Okay.
Preeti, you go ahead with your case. We will come back for another round of discussion.
Correct. So as we discussed, now that we have the presence of an actual optic neuropathy as versus just ischemia, we decided to admit him. We got in touch immediately with neurology and hematology. He was admitted for inpatient management of his electrolytes and hydration status, as Dr. Good suggested. We did decide at this point that he was still not systemically stable to even consider any surgical measures, but we did think that we would start now on Diamox, because that had basically been the plan earlier, but he never followed up. So he was started on Diamox 250 milligrams twice a day as an inpatient with a careful monitoring of his electrolytes and hydration. We did repeat imaging. A repeat CT venogram showed an improvement, a mild improvement in his thrombosis, but definitely not worsening. And LP was deferred since he was on anticoagulation. And we slowly titrated and bumped up his acetazolamide to about 1.5 grams a day. We did this with just 250 milligrams a day per week, a repeat blood metabolite panel just to make sure that everything is stable. And then he was maintained on this. These are his serial photographs over the next few weeks. As you can see, he was getting better, but really, really slowly. At no point did his vision get worse or the field get worse. Now, at last follow-up with the ophthalmology clinic, this was about 7 months after his acute presentation to the ED. His visual acuity on the right was 20/25, left was 20/30. So it was better. The colors were stable. He did not have any red desaturation now. He still had a small APD on the left. His motility was full. And this is what his discs look like. He still has some edema, but you can see it's much better than before. The left, however, does have some pallor now. So he was maintained on acetazolamide and anticoagulation, now was on Xarelto as determined by hematology. These are his fields at that last visit. Still has a little bit of the enlargement of the blind spot. The left is definitely still worse, but it is better than that acute presentation when he presented to the clinic. These are his OCTs at that final visit. We can see here that the ganglion cell analysis does show some thinning of the ganglion cell layer in both eyes, again worse on the left. And the retinal nerve fiber analysis does show that there is still some persistent edema. So at this point now again, I just want to ask the panel, what is the role of OCT in your practice? Do you do that for the diagnosis? Do you plan that as a part of the follow-up? Or do you use the ganglion cell layer complex to prognosticate? And in this particular situation, what would be your follow-up plans? What investigations would you repeat and how frequently?
Yes. I'm happy there's a good outcome, Preeti, because the way it started, I was sure it will end up poorly. And to be honest, I mean, this kid had I'm debating for the pleasure of debate. This kid had 20/60 vision. He had a severe optic neuropathy in his left eye. I would have been from the start, and he ends up with 20/30 and still with severe swelling, this swelling, and GCIPLs are gone. They're all in red. I would have probably been more aggressive, or at least discussed this more aggressively with the neurosurgeon, but I mean, there is no truth. This is just one of the options. To answer your questions, OCT, it has a quite limited value, I think, for the RNFL measurements. What we know is that the total retina thickness is probably more interesting because the RNFL above 300 microns, it just goes off. Especially in children, there is no normative database. However, as you suggested, I think GCIPL has a high value because it tells you if there is neuronal death, retinal death, as opposed to somebody can have a reduced RNFL improvement, apparent improvement of the RNFL thickness, which is just axonal death, in fact, not necessarily improvement. So follow-up plans, I think it would be what you suggested. I think GCIPL is critical. Visual fields, as you say, neurological, all nothing really exceptional. Investigations, just standard things. I think it's a good outcome.
Yeah, I think there are two main things comes in this case. Whenever the patient has a thrombotic episodes, just antithrombolytics will not take care of this. And we need to be aggressive. I think Preeti's case, they started because of the loss in follow-up. Probably the patient lost some more ganglion cells. Otherwise, probably this patient would have had even better outcome than this. These are the two things. And the second question, what is coming from the audience is, how comfortable are you in starting acetazolamide in this kind of situation? And we already had two opinion about this case, medical versus surgical. I would let Clara to answer first, and then we will come back. So how is that, Clara? You want to go ahead?
Well, I agree with Dan that I thought this will end up very poorly, and I congratulate you on, I mean, it was clear that you have to admit this patient. Luckily, he didn't come even a month later, because then he might have been blind already. Anyway, you admitted him, and you, of course, before just doing optic nerve sheath fenestration, you looked at his whether this is feasible at all, and how his systemic how he's functioning systemically. So that was definitely good, very good even. But he did lose a lot, and for the future, for any future increase in intracranial pressure, you have you have a problem, because he's at least old enough to do good visual fields. So you have visual fields to look at, and you have the OCT, and here I agree the ganglion cell layer is the best parameter to look at continuously, but you cannot judge the papilledema anymore. It's actually, he has a lot of atrophy. your question was...
Yeah. Are you comfortable in starting acetazolamide in this kind of systemic problem?
Yes, I think it was necessary, because it was necessary at this point where he came and started losing vision. And I must say that I was impressed by this second appearance of the disc, mainly the left disc, but actually both of them. And there is sometimes a point of no return in these cases. And I think you just got it in time. And for that, Diamox is a very good short-term measure before you can proceed with some, before you can decide what to do next. And if you can continue, and you are very good at going slowly up with but quickly enough with the doses to have an effect, but to not to get his electrolytes and everything totally out of control. So yeah, he was lucky, but he has a deficit now, and any future attack will be difficult to judge. And for that, luckily, we now have the OCT, and he's old enough for visual fields.
Okay. Two final comments from Dr. Good and...
hey, Ramesh?
Yeah.
I just wanted to ask the panel one thing.
Yeah.
So we wait and watch these kids lose vision while the edema is going down and the nerve is getting. Is there any role for systemic or topical neuroprotective agents, intraocular pressure measure, lowering agents, directly lowering intraocular pressure, or optic nerve sheath fenestration to reduce the local damage to the optic nerve while we're waiting for everything else to get better? I found it frustrating to watch and wait for the optic nerve edema to go down rather than treat the optic nerves directly.
Yes, I fully agree with you. I would have gone for optic nerve sheath fenestration on the left side, but because the kid ends up with quite significant atrophy. Now, the other questions, I don't think there is solid proof that there is any neuroprotective drug systemically or locally. Maybe the other members of the panel think otherwise, but I don't.
Dr. Good, you have any?
Yeah.
Yeah.
Well, I think it's understandable that as neuro-ophthalmologists we're focusing on the child's vision. But we shouldn't forget that he has deep vein thromboses in his iliac system, and he's got probably pulmonary hypertension as well. This could be fatal, and so stopping heparin is risky in this child, and one could have considered doing something about those thromboses lower in his system. I'm on board with Dr. Hurdle. I think the idea that doing something maybe to lower the intraocular pressure might have been helpful. I would have been very reluctant to stop the heparin, though, in this child's case, which would mean probably precluding doing optic nerve sheath fenestration.
The problem with lowering in the intraocular pressure is that the translaminar gradient will be then increased, and the problem on the optic disc will be probably getting worse. If anything, intellectually, it might be interesting to increase the intraocular pressure to reduce the conflict at the lamina level.
Yeah, that's a good point.
Okay, I think we need to move on because of the time factor. Thank you, Preeti, for the lovely case, and we had a discussion. There are some more questions from the audience. We will see if we can answer now or later. Now, I request Akshay to present his case. Preeti can stop share, and then Akshay can. When Akshay is setting up, there are some more questions being asked for the Menti questions for the audience. And Akshay, over to you.
I hope my slides are visible and I'm audible.
Yes, go ahead.
Yeah, first and foremost, thank you for the opportunity, and I'm really thankful. I've titled my case as Double Trouble, and we'll get to see why I have titled it that way. So I'm presenting a case of this 14-year-old girl who presented to us with drooping of the lids in both eyes and double vision since 5 days. She had a horizontal diplopia. There were no complaints of dysphagia, dyspnea, or dysphonia. No prior history of similar episodes in the past. There was no history of fever, There was no history suggestive of any neurological symptoms or any other systemic complaints. Her visual acuity was 20/20. She read N6 for near, no refractive error. Her anterior segment, pupils, and fundus were all normal. If we look at this external photograph, we can see here that she has ptosis in both eyes. And when we checked her extraocular motility, apart from the ptosis, she had a -1 adduction limitation in the left eye, and she had a 25 prisms of exotropia on the modified Krimsky test. So my first question to the panel would be, what do you think this is and what should be our next step?
Dr. Bill Good, you can.
Thank you.
Yeah.
So the things that come to my mind right at the top of the list would be myasthenia gravis. So this is a child with bilateral ptosis with a very acute or subacute onset of strabismus, a motility problem that's consistent with myasthenia. It would be ocular myasthenia. And so what my first step would probably be, even though the yield on this is low, to do the various tests for myasthenia.
Nice.
And then probably give the child a trial of Mestinon or something along those lines.
Rich, you have any comments? Rich?
I agree with Bill. That's the first thing I would go to. The interesting thing, the thing I can do, I do eye movement recordings on these patients because you can often detect the difference between a restriction and a paresis very easily by looking at saccades. And there are some characteristic findings with MG. And we do have a protocol in the hospital to do tensilon testing before and after eye movement recordings. And there's a diagnostic finding of hypermetric saccades that occur after tensilon. So it's a really nice way to diagnose at least the ocular association with myasthenia, whether it occurs alone in the 20 to 30% or as part of the systemic condition.
Thank you. I think Akshay will move on. As you're moving on, I think 2 more questions will come on menti.com. Audience can answer. There are totally 3 questions for this presentation. Akshay, please go ahead.
So we did an ice pack test. We do that routinely in the clinic when we suspect myasthenia. And you can see this is pre-ice pack. She has a ptosis, her palpebral fissure height is 6 millimeters. And there's a little bit of improvement post-ice pack test. It increases by about 8 millimeters. And we did a fatigue test as well. And the fatigue test was positive. I apologize, I don't have pictures of the fatigue test. So let's put everything together now. We have this child who's presented with ptosis and double vision. She has her ice pack test is positive, her fatigue test is positive. So just as Dr. Good and Dr. Hertel said, we suspected myasthenia. The only thing was we didn't really get any history of diurnal variation when we asked a detailed history. So my next question to the panel would be, what would be an ideal approach to work up a case of ocular myasthenia?
Yeah, we'll start with Dr. Good and then we will ask Dan Melia.
Well, the pharmacological test, of course, would be the tensilon test or a trial of Mestinon. Immunological tests, I suppose one could look for various diseases that could present like this. An LP might help, looking for elevated protein levels and things like that. I liked Rich Hertel's approach, doing electrodiagnostic tests. It's very intriguing that maybe an eye movement recording might be very helpful with this. And yes, the HRCT test could be extremely helpful. The thymoma, athymoma, is something that has to be considered and can be a very nice approach to this problem, if indeed there is a big thymus.
Yeah. Dan, do you have any comments?
Yeah, I absolutely agree with everything that has been said. It's a very elegant way to record the eye movements. I think it's nice. I would probably still discuss single fiber EMG if you have an expert in your hospital or repetitive nerve study. I would also, because the immunological test is coming up, I would certainly discuss the acetylcholine receptor antibodies, although we know that's probably positive in 50% of cases. just because the ISPAC test, I think it was, I mean, the way I understood, I may be wrong, it was 2 millimeters, which is really the limit of being positive or negative. I probably missed something, but I would certainly discuss GQ and B antibodies, and could it be a Miller-Fisher? I don't know if there were other viral pre-symptoms, but other than that, I agree with everything that's been said.
Yeah. At this point of time, I would like.
Can I add one little point, Clara?
Yeah. Go ahead.
You said there was no fluctuation during the day, but I would really ask this very simple question: whether after waking up for the first 2 minutes, the child and the parents think, "Oh, now it's over," but then it comes back. Because that's just as sensitive as the Tensilone test. So, did anybody ask that question?
Akshay?
Yeah, so actually the parents didn't report anything like that. That was one of the things. That's why I said that there was no diurnal variation. On waking up, there was not much improvement that they noticed.
Yeah. At this point of time, I would like to ask one word question, one word answer for that. We have audience from different parts of the world. In this kind of situation, they might have, they can get all these tests done. They may not get all these tests done where they are from, depending upon the location where they are. If there is one test needs to be done at this situation, what do you think that is? I want 4 or 5 of you to answer. Just one test for the benefit of the patient and the diagnosis. What is it? What could be the test? Ideally, we can all do this, but depending upon the area where they live. So, Dr. Good, you have one test. What do you do at this?
Well, I think it's a good question. In many parts of the world, people simply don't have access to some of these diagnostic tests. I have hoped that there would be Tensilone everywhere, and I would do a Tensilone test.
Yeah. Nowadays, I think Tensilone is not available all that freely. I think neostigmine, many people have access. Yeah. Clara, what do you think? One test? Unmute your mic, please.
Well, now, as I said before, actually the sleep test has been validated as being just as sensitive as the Tensilone test. So, of course, Tensilone test is easier to do, but I would even have the child in my office for 2 hours, closing her eyes, and then coming and seeing whether, the motility improves and the ptosis improves upon awakening in the very first moment. So sleep test.
Thank you. Dan?
All of the above. I mean, it's Tensilone. If there's only one, if it's available, neostigmine will be good. Sleep test is very sensitive. If you don't have Tensilone, is a good alternative.
I've asked the same questions to all the audience. We will know what's the answer from different parts of the world, whether they will do all of the above or one of the above. Akshay, please go ahead.
Yeah, thank you, everyone. So we did a neostigmine test in the operation room, and there was no change in palpebral fissure height or in the extraocular motility even after 15 minutes of doing the test. And we did a HRCT and an anti-acetylcholinesterase antibody. The anti-ASH antibody tests were negative, and the HRCT was normal as well. So again, I would require help from the panel. What do we do next?
I guess I'm first.
Dr. Good, yeah.
Okay. The words "uh-oh" come to mind. And this doesn't rule out ocular myasthenia, but it doesn't help any to have negative tests like this. And then you start asking questions about Miller-Fisher variant and other quite rare disorders where there are ocular motility problems such as this. Did the child have an antecedent viral infection of any kind?
No, Dr. Good, no antecedent viral infections.
Okay. I don't know, maybe the next best thing would be to to do nothing and just see what happens over the next few weeks.
Anybody would start on a therapeutic trial for ocular myasthenia at this stage? Or think of any other diagnosis at this stage?
There are other diagnoses. I mean, CPO hasn't been ruled out at this time.
Okay.
So this is a non-fluctuating doses with diffuse eye movement problems. Now I would be really very interested to have electrophysiology if we have EMGs that can be done before discussing, muscular biopsy would be probably a little bit aggressive, but I would certainly like to look at the fundus, to look if there's pigmentary changes. But it's worth discussing, as Dr. Good was saying. I think it's absolutely right. Nothing rules out myasthenia, and it can still be a very fundamentally clinical diagnosis.
Dr. Landau and Rich,
Yeah.
you want to make any comments, please?
Well, I will throw in something quite new, which was actually developed in Zurich, the ocular vestibular evoked myogenic potentials. This is not invasive and quite sensitive for myasthenia and OVAMP. I have not time to explain it all, but it's really very sensitive for myasthenia. It seems to be a good non-invasive way to electrophysiologically show that there is myasthenia. But I think in terms of what to do next, I would also wait and see if there is kind of an urge to do something, then maybe give mestinone, for a while and see how that affects the situation.
Just to be sure we didn't miss something, the pupils were normal, right? This is not botulism.
No. Pupils are normal.
Yeah.
Okay.
Rich, you have any comments?
Yeah, I don't know. We all have a different philosophy with this. I don't like to wait if the patients are having symptoms and the family wants to do anything. So I like the idea of giving her a trial of mestinone, which sometimes in all of clinical medicine, sometimes our treatments are also ways to diagnose. And so if she gets better on mestinone, that also assists with the diagnosis. Obviously, I can do the tensilon with eye movement recordings. It's interesting what Clara is saying, because the eye movement hypermetric saccada has been a sensitive measure for a long time and is also non-invasive. So it would be interesting to compare the eye movement recording to this VAMP study. Maybe we can talk later about that.
So I think differential diagnosis-wise, the CPO came. Akshay said there are no pigmentary retinopathy. I think there is a more or less kind of consensus at this point of time to start some kind of trial. That's what it looks like at this point of time. I just wanted to ask one more question. How responsive is mestinone in children, or do you start steroids for this? Just for the sake of discussion, I just wanted to complete that part at this point of time. Do you rely more on mestinone or steroids for myasthenia?
Was I asked, Clara?
Yeah.
Yes.
Please.
Well, I must admit, I actually pass these patients over to neurology and in children to children neurology. So I don't have much, I can't really say much on that.
Dan, you have any comments on that?
Yeah, so we know that mestinone works much better on doses, and it probably doesn't work at all on eye movement. So I think as a, to reinforce that therapeutic test is a nice way to do mestinone, but we know it won't work on eye movement. So if anything, I would probably rapidly move on steroids.
Okay. Dr. Good, you have any final thoughts?
Yes, I guess I agree with that. I think the nice thing about mestinone is it can be viewed as a diagnostic test. Once you start a child on steroids, that's also diagnostic, but then you're sort of on a slippery slope. How do you deal with the steroid treatment at that point? Do you taper it? Do you keep it going? It's not a benign drug over the long haul. But I think steroids would probably be more effective in diagnosing this.
Thank you so much. I think I've asked the same questions for the audience as well. What are the diagnoses? What is the diagnosis? What are the diagnostic things? and what is the treatment at this point of time. So please answer them. Akshay, please go ahead.
Thank you so much, everyone. So we went ahead and got an MRI brain with contrast done. And you can see in this MRI that there is a thin cystic lesion around the midbrain with perilesional edema. And it looked to us like a possible case of neurocysticercosis causing nuclear third cranial nerve palsy. So we took the help of our pediatric neurology team, and they decided to treat this as neurocysticercosis with oral steroids and proton pump inhibitors. So she was started on tablet Visalone, 1 milligram per kg body weight, so 35 milligrams once a day for 1 week with a 1 weekly taper, and proton pump inhibitors lansoprazole. You can see we did a bit of a literature search as well. Pediatric neurocysticercosis, especially in and around the brainstem, it's very important to give steroids. It reduces inflammation around the cyst. And whenever there is either raised intracranial tension, or if there is a cyst in the brainstem region, then giving only cysticidal therapy can actually worsen the condition. It can cause a rebound inflammation and cause a lot of problems. So steroids are the first choice of treatment. Within initiating 2 weeks of steroids, we can see here her ptosis has disappeared. Her eye movements are better as well. And this is at 2 months follow-up. So pre-treatment, post-treatment, you can see the difference here. So I would just like to summarize. I think as neuro-ophthalmologists, we need to be prepared for surprises, avoid antihelminthics in brainstem cysticercosis. We all know myasthenia is a great mimicker, but here something mimicked the great mimicker. And I think when in doubt, it's best to do neuroimaging. Thank you so much.
Thank you.
Hey, it's Rich. I'm sorry, in the United States, this patient would have been imaged the first day.
Exactly.
I thought you had already had an image. So maybe we all assumed that, but that type of thing as common practice, at least here, would probably not have surprised us because all of these kids get neuroimaging as part of their myasthenic workup.
Okay.
I missed that. I thought that imaging was part of your initial workup.
So
You were saving that for us.
Everyone does imaging in this kind of thing first. Sure. Is there a consensus on that, Dan?
Yeah, I mean, I'm still surprised that the pupils are not involved. With that lesion, with that location, the pupils to be uninvolved, that is not explainable. I would like to have some proof of that. But I agree that imaging and such stable ophthalmoplegia with ptosis would be the first thing to do.
Yeah, I agree. I mean, we usually get these patients with their normal MRIs in their hands already, but that reminds me of a nice case which was published by Nicola Ragge and Bill Hoyt many years ago of a brain tumor absolutely mimicking myasthenia and not involving the pupils, in a similar location. So it's very weird, but it seems to exist.
I just got a nice note from Dr. Granite. Somehow these are coming through on my watch. He asks the question: was there a systemic or was there an eosinophilia? Which I would think if you had CNS neurocysticercosis, you would have seen just with a routine blood test.
Her blood imaging was surprisingly normal. Her blood workup was surprisingly normal.
Somehow the neurocysticercosis with one cyst there, it behaves a little bit different unless you have something on the eye and things like that. It's not that always you will have eosinophilia in this kind of thing, but I think always the myasthenia cases should get an imaging. May not be at the beginning, but at the finally before starting on therapeutic trial or something like that, it can. Because it was exactly at the nucleus, that's why the patient has bilateral. But if you look at the picture, I think the patient does not have any kind of too much of a movement limitation. The patient has more of an exotropia in the primary position. I think the patient has abduction limitation a little bit there on the right side. So any other comments from any of the panelists? Preeti, you wanted to make some comment, is it?
Can you hear me?
Yeah, we can hear you.
I couldn't. No, this was initially, actually, when Akshay was presenting and we were discussing about the steroid. Actually, that's the point I was going to bring up, whether we want an image before we do a steroid trial, just to make sure that there's nothing, I mean, before I saw what the imaging was.
Okay.
One more point. So even in fluctuating eye movements and ptosis, I think everybody needs a brain scan, as you said, Ramesh. I remember a case of Gordon Plant that we reported a lymphoma that caused fluctuating ophthalmoplegia. That was treated for myasthenia for years before being correctly diagnosed.
Okay. Thank you so much. We will move on to the next case, Dr. Hurtle.
Thanks for the presentation. Our next case will be presented by Dr. Ava.
Hello, everyone. I hope you are hearing me. I just tried to share the screen.
Okay.
Here you go. So, first of all, I want to thank to organizers of the WSPOS webinar to give me opportunity to present this case, and I hope I will stimulate discussion. And this is a case of the boy with concomitant allergic strabismus who presented at 14 months of age. There was a history that parents been noticing around 12 months of age that the left eye is drifting, which you see on the picture. And when he presented first time, we noticed that he actually likes to lift his chin up to look up, and there was a limitation of his right eye elevation around -1, and working diagnosis was possible brown. When he came back in March 2019, there was a left variable hypertropia, and inferior oblique overaction was more obvious, and he was referred to my clinic. When I saw him, there was no problem with his visual acuity, and eyes looked healthy. There was no concern, no family history, no past medical history. But what I noticed that he had facial asymmetry, which you can see on the picture below, that his right eye was a little bit lower, and the eye was a little bit proptotic and was looking a little bit smaller. So I was thinking that like sort of hypertrophy of the eye might be a little bit anatomical. And I looked at the mom, and there was a sort of similar appearance, and she had no ocular movement problem. But knowing that he had inferior oblique overaction, or it crossed my mind, yeah, possible left corner palsy or DVD, and the parents been keen for surgery, so I went ahead and listed him for left inferior oblique anterior transposition. On a day of surgery, I actually came across surprise because he started to alternate fixation, and there was obvious right hypertropia with a limitation of his reduction on -2 and ptosis. Pupils being normal, and he had disconjugate manifest rotatory nystagmus in the right eye, which was very variable. They were like a burst of nystagmus, and he had disconjugate right eye saccade, like hypometric, like corrective saccades when he was looking to the different gazes. And my question to the panel would be, will you proceed with the surgery, or what you would do at this point? Is anyone going to answer, or should I continue? It's Clara.
Bill, Dan, do you guys want to say anything at this point, or Clara?
Well, that's what about imaging? Of course, you know, now that there is unilateral nystagmus, which is newly discovered, and this child has been looked at previously by educated people, that would make me a little nervous. And I can understand that you kind of decided not to go on with the operation and maybe image and look for whatever, maybe a mass lesion, supracellular mass lesion, something like that in that direction. Vision was normal in the right eye and no afferent defects in the right eye?
Correct. At that time, because I clearly freak out, I had a look at the fundus in theater, and I indeed cancelled his surgery, and I indeed listed him for MRI scan. And I was planning to do examination under anesthesia with forced action test under same GA, and this was the result. optic nerve sheath complex was found tortuous and slightly prominent optic nerve sheath, but optic nerve itself was unremarkable. And we did interval scan in October, 2 months later, and there was no obvious change, and there was no contrast enhancement. And orbit as well as brain was reported as a normal. Looking at his optic disc, you see that there's a maybe slightly paler pinkish disc, but I still think it's within normal limit because he's a blonde boy, blonde fundus. And his visual acuity has been normal, and therefore I decided to monitor him closely and saw him again in the clinic. And in November and January, his right eye vision was worse consistently. So my question was, is it nystagmus causing it as a problem, or amblyopia because of his squint, or there is optic neuropathy which I need to be worried about? So I gave a trial of the patching of the left eye 4 hours on Saturday only for 2-3 months, and then he came and ordered an electrodiagnostic test. Pattern BP confirmed macular pulsar dysfunction. In the right eye, the response has been vivid and broad, around 120 milliseconds. The left eye being very broad, and there was no obvious composite chiasm or hemisphere dysfunction. Unfortunately, he didn't tolerate ERG. His vision in February after patching was equal 0.2 logmar. We saw him in March, and we managed to do first-time prism cavities because he was a boy who was very difficult to be examined, and every time he came there was some surprise, and we've been relying upon the report of the parents what they're observing at home. And that time I asked them to bring the old pictures as well as try to do video whenever they see there is some odd ocular movement. And you can see that he actually likes to fixate with his right eye. When you clearly see his left eye hypertrophy with superior oblique overaction, when you make him to fix with the left eye, you can see sort of pseudoptosis because of right hypertrophy. But it's very difficult to comment about his right eye elevation. I found inconsistent in the report, and even my sometimes when I check it was full, but on other times it was looking like the limitation of tubes.
We can't hear you.
Can you hear me? Sorry.
Yes.
Go ahead now.
Yeah. Okay. Okay. So this is when his cooperation was exceptionally good, and we did ocular movement photos. And I will just guide you through that. Actually, he's fixing with the right eye on the up gaze and down gaze, as well as on his right gazes, but he's swapping fixation and fixing with the left eye on the left gaze. And just showing that he is actually having full depression in the both eyes, and is almost symmetrical. I'm showing this, and then you can see in the central image the difference on the like a palpebral aperture setting, that the right eye is inferiorly. So looking on his superior oblique under action in question mark on the right down gaze, is it pseudo under action, or are they, because that right lower lid inferior position? Something to think about. And then what else we've been noticing, that he started to have obvious sort of narrowing aperture on a deduction when he's looking to the right or left gaze, and it's bilateral. Then you can see that asymmetry of the palpebral aperture and setting of the canters. And then to make things more complicated, I noticed anisocoria. Now, anisocoria was noticed in that visit in around September, November time, and it's always the right pupil which is smaller, but there are normal reaction and the difference in the pupil, at least when I see him, and this is again not consistent, because when the autopsy see him, pupils are isochoric. When I see him, they are anisochoric, and you can see it nicely on the pictures as well. The right pupil is smaller than the left. And if I will try to sort of do this and share screen again, but get you through videos, I will show you a few sections of his, if it's going to work. You can see this is that time when we've been asking to patch his eyes. As far as nystagmus, I noticed these rotatory bursts intermittently variable on the right eye. There were a few jerks on like a abduction beating nystagmus. But he had this rotatory nystagmus on the left eye in the clinic as well. This is a video when he was watching some movie in front of him and he's got his head posture. But what's happening when he's fixing with his right eye, left eye is going up and there you can see like sort of jerks. Is it like the latent component toward the fixing eye and his right eye is fixing eye and it's sort of suggesting fusion maldevelopment nystagmus component? And then there is another interesting, he is able to get his left eye to fixate and you see his abduction full. And then when he will come back, he will go back to his right head tilt position and fixing, which looks like right eye. And then when his cooperation has improved, we got further video, and this is because of the COVID, and I was carrying on the phone conversation or phone clinics with mom. We've been posting the videos and photos. We actually found interesting this. That is clearly fixing with his right eye, and there are problems that his saccades, and you will see it soon, could be disconjugate. I will put it back. There's something which blocking that left eye working together, and you see the nystagmus is more obvious on his left eye. So, I think going back to presentation. Stop and share again. Sorry, I have to go back to my last slide, which showing you the presentation. This board made me revise almost our ophthalmology and webinars, or WSPOS, because are we dealing with congenital cranial degeneration syndrome, which there was Portner described before as a part of it? Was there resolved Brown syndrome? Is there combination of the Brown syndrome and left 4? Or was there DVD combination on top of it, which break his fusion mechanism and he ended up with FMNS? Or acquired nystagmus because of his possible developmental anomaly of his optic nerve? That anisocoria might be physiological, but it was described as a part of CCDS. And I was shortly thinking the diagnosis of double elevated palsy or monocle elevation deficit is the option as well. So, or are we missing something? I would appreciate your opinion.
This is an excellent case, Ava. I'm sure that we'll have a lively discussion. So, Dan, Bill, and Clara, do you want to chime in?
Well, you know, I would maybe suppose this has so many aspects. You said it's an efferent and efferent case. So let's dismiss the pupil, okay? Let's say that the pupils are anisocoric physiologically. That makes it a little easier. Anyway, yes. And then, I mean, you are absolutely sure, and that's great that you did it, that he, you know, he didn't have the operation, but you did the forced duction test. So you can be sure that at least at that time, elevation of the right eye was possibly possible, was it?
That's correct. I have to mention, I did forced duction test the way how I do it, which I sort of do it every time before surgery, and I testing in all directions, so all 4 rectus muscle, and I do superior oblique as well. The way how I do it is actually I am gripping the forceps next to limbus, usually between 3 and 4 or 10 and 9. Do retropulsion a little bit and then moving the eye to supernasal, supertemporally, and feel if there is a bump over, which suggesting that there is a superior oblique, because I don't have too much experience with superior oblique, but then it was sort of good advice that try to do it on every case to get it in your hand to sort of have that feel. And in his case, it was interesting that his right eye was, to me, very lax. There was no restriction, because if I was thinking that there was brown, and I remembered advice from clinician what David Granat does, that his exaggerated force action test, that I might do something if there is a brown, but there was no restriction. If there was monocle elevation deficit, I was expecting inferior rectus, maybe a restriction, but there was everything normal there as well. And surprisingly, the left eye, I did find that bump, which would suggest that superior oblique should work. So that actually didn't help. And now when we actually testing him further, we actually managed to do Bilczewski test, and it's supporting for nerve. But then I put to discussion even skew deviation, because this could mimic superior oblique palsy. But he is so complex that I am great if you will help with further management or advise what to do rest.
Okay, so we can actually exclude Brown syndrome, right? You know,
Looks like?
Yes, the finding of the nystagmus and the maculopathy, or no, not maculopathy, but what you found on VEP, that would kind of point in a direction of some maldevelopment, condition, but not really visible on MR. So, I mean, what about, well, if this was a grown-up, I would maybe even try to do inferior oblique Botox in the left eye, to see what happens. But this is not a good idea with a small child. Do you have to do something now?
The parents are very keen to have something done. And originally, I think that doing inferior oblique recession, but not to let it go, because I don't do the myectomy. Do the recession with anterior transposition, but don't do J deformity, but put the muscle safe to see how this will affect his left eye upshoot. Because in his case, I believe that anti-elevation, even if we will achieve it, might be actually beneficial. And then later, I didn't mention that you saw it on a slide, he's got convergent squint. I always said that actually I want him to stabilize the morphopathy and do the horizontal surgery later. But because I now seeing this palpebral aperture narrowing, I actually don't know if there's a combination, if his right brown resolved, and he's got problem with superior oblique, but maybe not neurological, but maybe mechanical. It's difficult. So
last remark, I have seen a few patients, very few, with totally anomalous anatomy of their muscles. So what you showed us in the MR was a coronal picture and the muscles, the four muscles looked normal, the rectus muscles, but you can't always see it. But that could be also some possibility of an anatomical abnormality. But I think I could add this.
I could probably add this, because how I ended up I'll seek for advice. I wanted to review that MRI scan, and I was waiting for a response of one of my neuroradiologist colleagues, but at the end, help came from some of the ophthalmology colleagues. And you can see this corona scans, and I was pointed by someone that maybe that left superior oblique doesn't look so normal.
Yeah, it looks.
Or right one is more thicker, which was blocking that inferior oblique and simulated brown.
Mm-hmm. Yeah. Okay, interesting. Very nice case. Let the other people give us some more ideas.
Bill, let's have your thoughts, Bill.
Yeah, well, yes, it's a complicated, interesting case. Thank you, Eva. Just one question before I make my comments. This started when he was age 2, or it was noticed when he was age 2?
No, no. He presented already 14 months old. And the parents said that they noticed, you see, if I will go to my first picture, that left eye upshoots. But there was no obvious head posture. Only on testing, he just liked to look up with the chin up. And there was original right elevation deficit. Therefore, was the idea maybe brown. But then he came a few months later, and his left inferior oblique started to be obviously overacting.
Okay.
And then the story was unfolding further like I presented.
Can you go back to the last slide that you were showing, Eva? No, the word slide.
Words.
Well, anyway, let me run down my list here. And I'm going to sound like a broken record, but I do think you have to always consider myasthenia gravis in a situation where you've got some unexplained strabismus problem. And there's quite a bit of variability in this boy's strabismus. And so it's on the list. I'm not sure it's at the top of the list, but it's something to be considered. I agree with Clara's comment about the pupils. Hard to make a case for this being anything like a Horner syndrome. The ptosis exceeds what you would normally see. In fact, I think the ptosis is kind of a pseudotosis of the right eye. It's because his eye is hypotropic and it's bringing the lid down.
Yeah, I can show this. That's beautifully showing. Because when he's in primary position, there is no ptosis. It's only on his down gaze. But the palpebral aperture is smaller, but it's that anatomical variation.
He can elevate his right eye, but I think what you see in primary gaze when he's fixing with his right eye is sort of a secondary deviation where he gets a big left hypertropia because of that. So it doesn't bother me that he can get the right eye up. It just means that that his ability to generate superduction or elevation of the right eye is impeded for some reason. Basically, what I would do in this case is avoid surgery, just like you've done, until it becomes clear exactly what you're dealing with. You know, you could do an inferior oblique myectomy or whatever you want to do, but I think you would be dealing in this case with what is a pseudo-inferior oblique overaction, because he can't elevate the right eye very well, and so the left eye goes up fine on adduction, and it makes it look like he's got inferior oblique overaction, but in fact, I'm not sure that that's what the case is. I'm not sure that would be the wrong intervention either, but you really want to be sure you know what you're dealing with. And certainly cranial disinnervation syndromes can look any which way. So it's not out of the question that this could be a cranial disinnervation. But since you've got good tests that show that he doesn't have any sort of life-threatening or really urgent problem, and you're managing his vision very nicely, I'd be inclined to watch and see what happens with this, and/or do a couple of tests for myasthenia.
All right.
Can I make a comment, Rick?
Okay.
Yes, go ahead, Ramesh.
Yeah. Can you go back to the face picture, Eva? You wanted to the facial.
Face picture this? Or original first one here?
Yeah, be there. I feel there is some kind of hypoplasia on the right side of the face. Mm-hmm. And the last picture you showed some head tilt on one of the pictures. Maybe you can go to the last CT scan. Yeah, this one.
Yeah.
This one. There are two things coming to my mind immediately. That eye looks that side is hypoplastic, or that eye looks enophthalmos. If it looks enophthalmos, I think there is a problem with the inferior rectus, which probably on the right side you have ruled out with your MRI scan. If you go to the last MRI,
Could interrupt, sorry, Ramesh, there is no enophthalmos. Actually, that eye is like more proptotic, that you can see it on the MRI. That eye is actually pushed forward, that right eye. And I'm not sure because like that optic nerve is too long for the size of the orbit.
Okay.
And it's tortuous. And then if it will go back to this one you wanted.
Yeah. I think it may not be enophthalmos. It's a bony abnormality there because of the face tilt. I see definitely a smaller superior oblique on the left side here. If you really look into all the cuts, from starting from the top, we can see superior rectus very clearly, inferior rectus normal on both sides, medial rectus and lateral rectus. In all that 5 picture, except the second picture, I see the superior oblique on the left side is smaller. Somehow, I think he is trying to fixate with that paretic eye. That's why he's not going to have any kind of constant tilt. That's what, to me, it looks like it's a superior oblique palsy on the left side. These kind of cases, I think you can make use of imaging. That's what my opinion on this case.
So will you go for surgery or will you agree with Bill to wait?
Waiting is because he's already developing the tilt and the hypoplasia. It's already there. I don't think so.
The other thing is, we never really proved stereo vision. I don't know what's triggering his anomalous head posture because he got it very early and it's fixing this the right eye, which actually the left eye is disconjugately wandering upwards. So not sure.
So Eve, I wanted to talk about the AHP. The head posture is driven monocularly by this patient because he has no binocular function.
Yeah.
So it's either driven monocularly by a paresis or restriction in the fixing eye, or by, as you suggest, by an adduction or torsional null due to the FMNS. So recordings will help that. If he has FMNS, he has a torsional or adduction null, and that's driving it. You can see that change with recordings. But my sense is that he's probably using his AHP, which is variable, because he's monocularly fixing against either a restriction or paresis. He can't move the right eye up because regardless of how the forced duction feels or what it looks like, he can't move the right eye up because either the inferior compartment is restricted or the elevators are paretic or a combination of those. Whether it's one or the other or combination, you don't know for sure. But I think he's posturing monocularly mostly because of the duction limitations, not because of the nystagmus, although he may be. And the only way to do that is to do a recording and see which one, if he has a torsional. What you're suggesting is the saccadic movements can be hypermetric movements associated with weak or restricted saccades. Restrictive or paretic movements can cause the large saccades you see as well. But again, this is where eye movement recording really will help you if you can have access to that.
The problem with eye recording was that he wasn't have obvious manifest deviation in primary position on his recent visit. And because it is a rotatory component, and I will probably let run this, sorry, how he is watching, and we can continue discussion.
Sure.
Because
you can't make a diagnosis of nystagmus by looking at the eyes. I can't. And
when you look at Rich on this moment when he was looking with his right eye fixing and his left eye was moving up and hold on, let me just go back.
Yeah.
So he's fixing with the right eye and left one is looking up and doing this like AB ducting towards right eye fixation jerks.
Yeah, so when I put my finger on the pulse, the heart is doing something. I just can feel it. But in order to diagnose what the heart's doing, I got to do an EKG. So no matter how much we describe what we see happening with the eye, to try and deduce what's actually happening with the eye can virtually be impossible, especially in these situations. Yeah. So I don't guess at the diagnosis. I just don't guess.
And as for your management, would you just sort of wait for recording, or would you do some surgery?
Well, I would discuss this a lot with the parents. So I don't like the children to have to use their heads to see. I just don't think that that is a satisfactory way to grow up. I think it affects the neck, back, face, and spine. I think it creates an anomalous egocentric localization. So if I can somehow improve their ability to use their fixation, their gaze without using their head, then that's what I'll do and discuss that. So, and I try and not make this complicated. He cannot move his right eye up. So I need to do an operation to get his right eye up, not the left eye down. The left eye's fine. It's the eyes, as Bill said, he has a fixation duress, or as Jampolsky used to call it, that's why the left eye is going up. So try and get the right, whatever your operation is to get the right eye up, whatever that is going to be. I would use forced suctions in the operating room like you did. And if the inferior compartment is not restricted at all, then I would do maybe a transposition procedure to try and get the right eye up.
Yeah. Yeah, that was my sort of plan, but like I said, inferior oblique left and then transposition of the right medial rectus and lateral rectus. Or, yeah, that's. And Ramesh, what's your opinion, if you don't mind me to ask?
Yeah, any torsion on the left side, that was one of the questions asked by many on the podium. Any torsion, fundus torsion was seen in any of that?
Yeah, that was something is what I'm not able to assess on him, because he's now much better with photography. When you look at on his fundus photos, there was sort of suggestion that actually there could be, hold on, it was up, cyclotorsion on the left and excilotorsion on the right, but that would fit with the skew. But then I never had a child with skew deviation. And
in terms of my opinion, I think I would carefully do a force traction test on both sides.
And would you mind to describe how you would do it? How you would do traction test?
Yeah, we can, we have to kind of retropulse the globe and hold at maybe 7 o'clock and 2 o'clock position, and do a rocking movement with 2 forceps. You can do it in even with 1 forceps. Eye should be elevated and adducted position. You can do that rocking movement. You can really feel, that's one of the things to confirm in this case whether the superior oblique is hypoplastic or aplastic. That's the first thing I would do. With the regards to the measurement, the patient has 40 prism diopters of hypertropia. Depending upon that, I would do 2 muscles. If the superior oblique is really, really lax on the left side, you can do inferior oblique and the tuck of the superior oblique after inspection. If it is not, just the right inferior rectus is tight,
it's
I would follow what Dr. Hurtle said. It's not tight. So then my procedure will be inferior oblique and probably superior oblique, after knowing the laxity of the muscles. This is what I would do. I think it's time to wrap up now. We have already 3:28. We had an excellent case of pseudotumor cerebri, which responded very well with a little bit of delayed treatment. And we had double trouble with we thought like it was myasthenia and it was something different. With the third case, I think still there are few more opinions coming. We are still not sure, and even at this point of time, probably we need to have some discussion with the parents, and then we can take a call. I just wanted to quickly go through the Menti questions. Which part of the geographical location the people are from? 53% are from Asia, 13% each are from North America, South Africa, and Europe, 10% are from Middle East, and rest of them are from Africa and Australia. Australia, it's really late, early morning there. What do? Most 70% are pediatric ophthalmologists. We have 10% neuro-ophthalmologists, 7% general ophthalmologists, and we have 8% of optometrists. For the first case where Preeti came up with the case, the diagnosis was unanimously pseudotumor cerebri. What was their choice of treatment? 70% said that they will start Diamox. 30% went for other treatment, maybe surgical, or not comfortable in using Diamox. The second case, the diagnosis came as myasthenia as the most common diagnosis. What test you will order? This was kind of interesting. Neostigmine was 31%. All test was 26%. So still in this case, 1/4 of the audience will do all test, but receptor antibody test as well as SF-AMG is 18% each. Surprisingly, only 7% do the HRCT. MRI was not a routine investigation during myasthenia work. Treatment-wise, we have a unanimous answer of mestinon, 60%. 40% said they will add steroid as well to the mestinon. The last case, the most common diagnosis what came up is a monocular elevation deficit, and the next one is superior oblique palsy on the left side, and the next one is congenital cranial dyssynervation syndrome. Choice of surgery, I can see everything here. Not sure, superior oblique tuck, right eye surgery for transposition, left eye inferior oblique surgery, and it's growing. The list is still growing. People said right inferior oblique,
Good
right
luck,
recession.
Thank you.
So Eva, still you have to decide. And what was the best part of the webinar? They all discussed the lively discussion. That was number one came up. I just want to share the final thank you slide with everyone. I really want to thank everybody, especially the panel and the presenters who gave their time for today. Thank you so much. Even if you have participated in this webinar, we will send you the participation certificate. Please email us on the email ID what you see, and all of you can become members of World Society of Pediatric Ophthalmology. It's for free, and you will get regular updates about that. Any one of you haven't watched the previous 10 webinars, we can go to this the site called www.wspos.org. There is a webinar column. You can go and click. And once you watch all the Strabismus webinar, we have made a survey for that. This is the link for this survey. You can find that link on this website as well. Please complete this survey before 30th of June. We will send all the PDF of all the questions which are answered for the first 6 Strabismus webinars. This is going to help us to make our webinars better for all of us. Please go and complete before the Tuesday, that is 30th of June. Please go to this survey. And we encourage every one of you and your colleagues to watch this webinar, which is available for all of you to watch. And we encourage all of you to join us for the rest of the 5 webinars on the next 5 Saturdays, and also the WW Connect, which is going to be a big part of the World Congress of 5th World Congress, what we are really planning. Please join us on the WW Connect, the details will come in the next few weeks. I really want to thank all the panelists who have come and helped us to come up with this lively discussion. Thank you, everyone. Thank you for the very great, nice 3 cases which are presented today. Thank you, Akshay, Preeti, and Eva. And thank you, Dan, William, and Clara for your participation. And I thank Rich to co-moderating this session. Today's webinar is hosted by the NTOD International. Week after week, they are helping us to host this. Thank you very much to the NTOD team. Last but not the least, Akila and Dara for our WSPOS admin team, who are regularly working every week after week to make this a huge success. And at last, I would like to thank all of you who are watching from around the globe. Thank you so much. Have a great day.
Thanks, Ramesh. Thanks, everybody. Have a great
Thank
weekend.
you, everybody.
I just want to leave with you this image in the World Congress of 4th World Congress in Hyderabad. Until we meet again. Thank you.
Thank you.
Bye-bye.
Bye. Thanks.
Bye-bye.
Bye.